This year I'm talking about the diagnosis of patients with dizziness and vestibular disorders in the emergency department. Dizziness in general is more common in women and more common as people get older. We do see differences in the way people are diagnosed in the emergency department. So for instance, we know that stroke, which is a concern in patients with dizziness and vertigo, is more often diagnosed in older patients, and younger patients are actually sort of disproportionately likely to be missed just because it's not on people's minds. The majority of people who come to the emergency department complaining of dizziness are actually complaining generally of episodic symptoms. They're not usually folks who've necessarily fallen and fractured a hip. Obviously those patients get admitted immediately, from a surgical standpoint, but the majority of patients have had intermittent dizziness symptoms or new acute dizziness symptoms that have been going on for hours or days, occasionally weeks, and those patients present for care, and the task of the emergency physician or the consulting neurologist is to sort out whether it's a benign inner ear condition or a dangerous neurologic one. That's typically done when it's done by someone who has expertise in the area by dividing the problem up into those patients who have acute continuous symptoms and those who have episodic positional symptoms, and focusing then subsequently on eye movement characteristics that are specific for both benign or dangerous central causes. So for instance, in the episodic positional patients, we're looking for transient upbeat torsional nystagmus that's induced by the Dix-Hallpike test, the positional test for vertigo, and when that's present we can just treat the patient and send them home. Whereas in a patient who has acute continuous symptoms of new vertigo or dizziness that's been going on for hours or days, and the concern is stroke versus vestibular neuritis, we use the HINTS test, which looks at the head impulse test of vestibular function, the presence of direction changing nystagmus with gaze right and left, and the presence of a vertical misalignment of the eyes or skew deviation. So typically what happens in common practice nowadays is that most patients seen in the emergency department with dizziness will, if they're older, will get a head CT looking for something that's catastrophic. And when that's negative, as it usually is, the patient will be given anti-vertigo medications and sent home if they can be sent home. Typically, the diagnosis is not made accurately. Some of the studies we've done suggest that, in fact, maybe 80% of the patients with benign inner ear diseases are misdiagnosed. So we know that on average we're not doing a great job in that space. We're also concerned that perhaps 1 in 3 strokes is missed when patients present that way. So there's a big evidence practice gap in this space. There are a couple of different approaches that have been taken. Obviously, the standard historical approach to getting new evidence into practice has been focused around publication in the medical literature, changing the educational process, changing what's written in textbooks, and certainly we've been working along those lines, but it's a very slow process. That's why it takes an average of at least 17 years for new information to sort of make it into clinical practice. And in this case, we've probably been working with outmoded paradigms that are 40 years old, and for the last 5 to 10 certainly we've known that there are much better ways to do things than we're doing them now. So we're working more aggressively to apply technology-based solutions to try to change some of the current clinical practice.